Can everyone see my screen here? It says epilepsy surgery techniques and technology. All right, perfect. So, to get started, before we actually get into my talk, a couple of things I want to say. Number one, I uh, really understand the fear that people have when you talk about epilepsy surgery. Oftentimes what happens is that uh, I have patients who come in and they say, you know what, I would rather take all the medications in the world than try surgery. And I completely understand where that comes from. I think a lot of times if the person who's referred you, let's say the epileptologist or the neurologist, is not comfortable, oftentimes that has a part to do with it. Oftentimes it can just be related to the fact that brain surgery is a very scary thing in general. With that being said, myself, the neurosurgeon, the epileptologist I work with, all the epileptologists and neurosurgeons who do epilepsy surgery really do truly care about patients who have epilepsy. One thing I can tell you is that really, I don't have to tell you how devastating this disease is. And what I really find is that it's not really understood by the public as much as some of the other diseases, mainly because you don't see it the way you see Parkinson's or other types of problems. But I understand, how much it affects your family life, social life, how much stress it can bring. And so really the important thing here is that epilepsy surgery really is something that can potentially cure you of epilepsy. And we know in the literature that if you fail 2 or 3 medications, the likelihood of becoming seizure free with medication alone is almost zero. So let me get started. And the last thing I'll say is just one quick disclaimer, and that's that with with this surgery, with this my presentation, I do like to show pictures of blood and the brain, if that's okay. I'm going to do my best to give you a heads up before I do that, but I think it's important to at least get a sense for what we're talking about here. So I'm going to start by talking about the evolution of technology in epilepsy surgery. One thing that I'm very interested in, and one of the things that I've been able to really build up at UC Irvine, is the ability to bring technology to this hospital. Later on, we're going to talk about the surgical implantation processes, and specifically we have two. We have SEEG and subdural grids. And then we'll go into some of the neuromodulation techniques that we have, laser surgery, and then finally we'll just very quickly go into some of the most difficult to treat epilepsy patients, those being the patients with MRI negative epilepsy. So for those of you who've heard me talk before, I love this photograph. This is a photograph that's probably about 80 years old. It's from Montreal. This was a neurosurgeon that I really look up to. This was Wilder Penfield. He really kind of pioneered the idea of epilepsy surgery. And what he did, which was very different than what people have done before, was that he would actually do surgery in a way that he would stimulate the areas that were thought to be the epilepsy areas. And what he found was that it wasn't that the area is much broader than what he thought it was. And we really understand epilepsy surgery thanks to Wilder Penfield. What else you see is that the patient here is awake, and there's a neuropsychologist and the epileptologist all working in the OR at the same time, really providing the patients with the best care. That element of epilepsy surgery is unchanged. It is a team approach. Whenever you come to see an epilepsy surgeon, you have an entire team of specialists who specialize in neurology, epilepsy surgery, radiology, all the different fields of medicine. And they are able to really look at you and decide what the best option is for treatment. Lastly, I'll make a point to say that while this patient is awake, nowadays it's very rare that we offer awake surgery. Often, that's one of the questions that patients oftentimes will ask me is, do I have to be awake during the surgery? And no, that's almost never the case. And we're able to do a lot of the things that they were doing awake 80 years ago. Now we're able to do that without. Now, these are some of the tools that we use in epilepsy surgery that Dr. Penfield actually developed. These are, very effective, easy to use, they're safe, they're durable, and they're time saving. And what I would say is that nowadays the technologies we talk about are the same. The top one is we have now robots that help us do surgery. Those have to be effective and easy to use and safe. NeuroPace is our neuromodulatory device that we use. That's also very, very safe and effective. We have laser ablation, which I'm going to talk about a little bit later on. So I want to start by talking about robotic neurosurgery. I apologize again that I'm late, so I'm just going to very quickly go over this. The the important part to take from this is that we do use robots in epilepsy surgery. Now, with that being said, it's not that the robot does the surgery. We're not close to that level of sophistication. But what the robot does helps us be extremely accurate and precise when we are doing the surgeries ourselves. Um, there are different types of robots that are coming down the pipeline, and there's some that are actually going to be able to help us perform the actual surgery. But for the most part, the ROSA one, which is the robot you see in the middle, that's the one that most neurosurgeons rely on. We were actually the first on the West Coast to have this robot, and I use this all the time. In fact, the surgery I just finished, I used this robot to do our surgery. Um, so these are just some of the studies that we've done at UC Irvine, looking at the robot and our experience with epilepsy surgery. I'm going to just take a pause here and say that we're going to show how the process for surgery works, and we're going to use the robot in the process of doing surgery. If you're uncomfortable, I would just ask that you just take a minute to just kind of look away. We're going to go through this very quickly, and then we'll go back to talking about epilepsy surgery. So what I always tell patients is that there's two broad categories of epilepsy surgery. We have diagnostic procedures, which are the implantation of invasive electrodes. Those go electrodes into the brain. And basically those procedures just give us more information. The idea of those procedures is that we are able to figure out with better accuracy where the seizures come from. The other type of surgery are the therapeutic options, and those are the actual resective treatments, the laser surgeries, the surgeries that actually can treat the patient's epilepsy. Right now, I'm going to talk about these, which are the diagnostic procedures. This is the subdural grid. This is a larger surgery where we implant electrodes along the surface of the brain. And this is SEEG. We've kind of moved more to this type of procedure, the SEEG procedure, because of a few reasons. One is that we've become more and more comfortable and confident in the results. And then number two, it also allows us to get very good information in a minimally invasive process. So the next set of videos and surgery, they're going to actually show us performing the procedure. This is what the end result looks like. As I said before, you can see here that these are pinhole openings that we put in the skin. Unlike in the older types of surgeries, the grid surgery I showed you, that involves a large incision. I make a large window in the bone, place those electrodes. This is a much, much less invasive procedure. This procedure is very nice because when the patients are done, they may have a mild headache after surgery, which goes away after a day or two. But for the most part, they don't look or feel like they just had a major brain surgery. This is what we do at the beginning of the surgery. We come up with a hypothesis for where we believe the seizures are coming from. And this is our map. This is where I'm going to implant the electrodes. The next thing that I do is the patient is brought to the operating room, and we put them to sleep. Then we use our robot, which you can see here, to actually create those trajectories within the brain itself. Now, unlike what they did in the past, one of the things that we do here is we rely heavily on very, very sophisticated imaging tests. And what those tests do is they allow us to be able to visualize the blood vessels in the brain so that when we plan these electrodes, we're able to very safely place them without injuring the blood vessels. This is what the planning looks like. This is how we register the patient. So you can see the patient's asleep here. The robot is registering to that device. And then what we do is the robot now is able to go directly to the place where I targeted previously. Um, Again, outside of that, you see that I am doing all the procedure. I put the robot in the correct position, do all the rest of the surgery. The next step is to actually get into the brain. So this is where we use a drill to get down to that area. And then once we've placed this stylet actually creates a very, very small tract. This is less than a fraction of a millimeter in diameter. And that is the tract that we place into the brain. The next step is the actual placement of the electrode. And what you see here is that each of those little silver dots is actually one electrode. Each of those is picking up signal from the brain itself. Um, this is the final step, which is the bolt fixation. This fixes the electrode in place. The electrodes don't move once they're placed. Um, and really the benefit is, as I say, that it allows us to with very, very good accuracy, place electrodes in the areas we think the seizures are coming from in a safe and minimally invasive manner. Now, just for historical purposes, I show you how the subdural grids are placed. This is kind of the process. That's what the actual brain looks like. This is the grids that we place on them. And again, advantages and disadvantages of both. There are certainly advantages to this procedure. And although we do more SEEG than grid implantation, it's not necessarily true that grids have no value or use. There are certain patients in which it really is the best option for them. And so one of the other things I want to emphasize is that when we do these surgeries, each patient that comes in, we look at them and decide what's the best option that we want to recommend to that patient. Unlike in other types of surgery where it's kind of, you come in, you have an aneurysm or brain tumor, and you have the same kind of surgery, we really try and tailor the surgery to the patient. That, as I mentioned before, that whole process of having a team approach, that's really what helps us get the best results for our patients. So now I want to talk a little bit about some of the newer technology. I think this is some of the really exciting new technology that we have. This has really helped us improve the patient care that we can deliver every single day to our patients. So neuromodulation, we have three types of neuromodulation available. There's responsive neurostimulation with the RNS system, there's deep brain stimulation, and there's vagus nerve stimulation. And each of these have their own benefits and drawbacks. And what I'm going to do is just very quickly give you an overview of how all of these how they work. They're all FDA approved, and we do all of these at UCI and at all level 4 epilepsy centers. But you may have heard a little bit about each, and I want to kind of go into each of them so you understand them better. The first one I'm going to talk about is responsive neurostimulation, or RNS. The way that this works is that what we do is we localize where the seizures come from in the brain. If they come from an area that we're not able to remove, let's say, for instance, it's coming from the language area or the motor area, somewhere where if I remove that, we can potentially cause a deficit. In those patients, what we can do is we can implant this RNS device, and what it does is it acts kind of like a defibrillator in the heart. It constantly is listening for seizures, as you can see here. Once it sees that a seizure is starting to develop, it'll send an electrical stimulation, which oftentimes can stop the seizure or shorten its length, or abort it completely, or stop it, or reduce how severe the seizure is. We've had very good success with this device. We've done well over 50 of these procedures at UC Irvine, and our numbers keep growing. I have really found that it is an excellent option for patients if and when they're not resective candidates, laser ablation candidates, if they're not a patient who we could do a more definitive surgery such as a resection. Next option is deep brain stimulation, and one of the things about this surgery is that, unlike that other surgery, with deep brain stimulation, if you don't have the exact localization of the epilepsy, you can still do deep brain stimulation, and oftentimes we have very, very good results with that. This is a long-term study looking at outcomes after deep brain stimulation for epilepsy. And what you see is that over time, the epilepsy reduction continues. And so one of the things here is that you see that immediately within 1 year after surgery, about 50% of patients had a 50% reduction. At 5 years, you see that now 70% of those patients have a 50% reduction. So what does that actually mean to us? The important thing here is that over time, by stimulating the brain in these areas, and again, for some reason we don't fully understand, the brain is able to remodel and the networks are remodeled as well, to the point where there is a significant reduction in seizures over time. One of the things I tell patients immediately after the surgery or soon after these surgeries is that it may be that you don't notice a significant reduction in your seizures right away. It might take 2 years, 3 years, 5 years, or even longer. With that being said, these are also, as I mentioned, very, very difficult to treat patients. These are some of the most difficult patients with epilepsy to treat. And so, one of the things we have to do is give it time to work. Before these devices were developed, if you had a seizures that started from your language area or your motor area, for the most part, there weren't any good options that were surgical for you. So this has really kind of been a game changer in terms of helping patients with very difficult to treat epilepsy. Vagus nerve stimulation has been around the longest. This is a device that goes in the left chest wall and it stimulates the vagus nerve. For whatever reason, and again, we don't fully understand how this works, stimulation of the vagus nerve also causes changes and remodeling in the brain itself, which oftentimes can reduce the seizure burden for patients. Now we'll talk a little bit about laser ablation. I think laser ablation is another very important procedure that's available for patients. Let me show you, and again, just like with the SEEG I already showed you, you can see here that this is a minimally invasive procedure and technique. Unlike the surgeries of yesteryear when you would make a large incision, large resection, those kinds of things, in certain patients with certain pathologies, we are able to do these more minimally invasive procedures. Now, what you see here is what some of the patients, what we've done surgery for. So this is mesial temporal sclerosis. This is a good option for certain patients who have temporal lobe epilepsy. On average, we quote patients as saying about 50% of patients who have this surgery become seizure free. Now, the most successful surgery for patients with temporal lobe epilepsy currently is, and I believe for still quite a long time, will be temporal lobectomy. The reason for that is that we know that patients who have epilepsy, and especially in the temporal lobe, oftentimes it can arise from the mesial temporal lobe, but it can also arise from that entire temporal lobe. So the more that we're able to safely remove, the better the likelihood of seizure freedom. These are some of the other procedures that we can do. Hypothalamic heterotopia. This is actually a very difficult to treat lesion. Before the advent of laser surgery, it involved a major surgery where we would have to actually separate the two halves of the brain and then get down to the deep parts of the brain to actually remove that. Now, focused ultrasound is one of the newest techniques that we have available. We're currently working on bringing that to UC Irvine. Just like those other procedures, it doesn't involve an incision, but it's able to target the deep parts of the brain to ablate and treat those areas. Now, what I'd like to do is just very quickly talk about some of the most difficult to treat epilepsy, and those are patients who have MRI negative epilepsy. So what that means is that their brain MRI is normal. So when patients have normal brain MRIs, oftentimes if you have a lesion, that improves the likelihood of becoming seizure-free after surgery. So if you think about it, MRI negative patients are truly some of the most difficult to treat epilepsy patients. With that being said, at level 4 centers, at centers like ours, where we're very comfortable with it and very experienced with treating all types of epilepsy, these are some of the patients that we really work very, very hard to treat because we know that we have the ability to help them oftentimes. And so I'm going to talk a little bit about that. So these are what we would consider in epilepsy surgery to be our ideal patient. This would be this patient here. They have a lesion on their MRI. They have mesial temporal sclerosis, as you can see here. They have atrophy of the brain in the area where the seizures are coming from. And as I mentioned, this is a patient who would do very well with surgery, especially temporal lobectomy, to make them potentially seizure free. Now, oftentimes what we see are that we have patients like this. they're older, they have a completely normal MRI, they have a long-standing history of seizures. Oftentimes, they have seizures that we're not able to localize with scalp EEG alone. And what we know is that in general, if we can find where the seizures come from, we have about a 50% likelihood of becoming seizure free. So this study was done several years ago. It came from the Cleveland Clinic, and what they looked at is that that first patient I showed you, the mesial temporal patient, in the large centers across the country, those patients have started to decline. We don't see those patients coming to us as much as we used to. So what that tells us is that the more easy, the simple, the patients that we're able to treat and make them seizure free in the simplest manner, those patients have declined. And in the meanwhile, we're seeing much more of these very difficult to treat, very complex epilepsies. So the question is, how do we make these patients who have very difficult to treat epilepsy, how do we make them look more like the patients who have easier to treat epilepsy? Well, one of the things we want to look at is looking at actually where the seizures come from. So we know that when a patient fails temporal lobectomy, the most common surgery, generally that means that their seizures are coming from an area that's either outside of the temporal lobe, or the surgery itself was inadequately performed, or we weren't able to find the seizures before this actual surgery was done. Now, you may ask, well, what's the treatment for all of these? And actually, what I would argue is that SEEG, that procedure I showed you at the beginning, is the best option to treat those patients. And the reason is that with this procedure, we are able to target all the areas of the brain that are associated with the temporal lobe that aren't actually in the temporal lobe. And by doing that, we're actually able to better localize where the patient's seizures may arise. So in those patients, again, who have very difficult to treat epilepsy, we are able to implant these electrodes and really look for where the seizures might be coming from. This has really been, again, a game changer in terms of epilepsy surgery. Prior to this, again, as I mentioned, it was very difficult to find where the seizures came from in these certain types of patients. And more importantly, our seizure-free rates were very, very low. Nowadays, what we know is that if we can find where your seizures come from, if they come from the temporal lobe, we can quote between 60 and 80% of those patients become seizure free. If it comes from outside the temporal lobe, it's usually in the 40 to 50% area. But with SEEG and some of the other techniques that we're talking about here, we can really improve those outcomes significantly. So once we find where the seizures come from, then it gets onto that tailored approach that we talked about. So unlike what it used to be, as I mentioned before, we had very few options in terms of treatment of patients with epilepsy. If we weren't able to remove that area that you have epilepsy, we really ended up not having much in the way of good options. Oftentimes we go to a vagus nerve stimulator, but pretty much that was the best we were able to offer. Nowadays, not only are we able to offer resection for those patients who are good candidates, but also we've now gone to a lot of minimally invasive or non-invasive techniques, which have really allowed us to expand the ability to treat patients. So if there's one thing I'd hope you take from this is that, well, number one, I think that it's very important to understand that not everyone is a candidate for epilepsy surgery. With that being said, if you've failed 2 to 3 medications, if you've tried all the different medications, every time you get a new medication, you have a honeymoon period, you have a reduction in seizures for a short period, and then you go back to having seizures. We know that no matter how many more epilepsy medications you try, the likelihood of becoming seizure free is almost zero. Those patients we know are also oftentimes can be considered candidates for epilepsy surgery. The only way to really know that and to know whether you are a candidate is to be seen in a level 4 epilepsy center. What that means by being level 4, what that tells you is that they have all the different surgical treatments available, as well as all the best diagnostic procedures to really understand where your seizures come from and be able to treat you in the best way. So these are, available at all those types of centers, as I mentioned before. Number two, what I hope that you take from this talk, excuse me, sorry, is that Epilepsy surgery is a very, very safe procedure. As I mentioned at the beginning, I really, I myself, as well as all the epileptologists, all the people that care for people who have epilepsy, we really care and try and help patients and cure them of their epilepsy if we can. We all very much understand how bad of a disease this is and how devastating it is and how much it affects your quality of life and social abilities and all the other things that are associated with having, a good lifestyle. And so we're able to do that, and that's what we really care about. So um, as I mentioned here, UCI, we've been very busy. We're one of the busiest epilepsy centers on the West Coast. We do all of the different types of complex epilepsy treatments, everything I've talked about today. We do those types of surgeries. Our outcomes have been very, very good. We're very fortunate to have really good experience with a lot of these, with patients who have epilepsy. And so, final takeaway points, there are continuing to be new technologies that are available for epilepsy. I highly recommend being evaluated at a level 4 center where we're able to really look at you and decide what we recommend is the best option for you. While brain surgery obviously is a scary thing, and hearing the idea of having someone operate on your brain is something, that people get very anxious about, what's very important to remember is that epilepsy itself has its own very, very bad problems. I've seen patients have car accidents, get severely burned, drowning, depression. All those things are associated with epilepsy in and of itself. And in our experience, the benefits of epilepsy surgery, especially if we have the ability to make you seizure free, far, far outweigh the risks of the surgery and far outweigh the risks of having epilepsy itself. And so, finally, with that, I just want to say thank you all for coming to my talk. If there's any questions or anything I can answer, I'd gladly do that now.
Yes,
Does,
there
mhm.
are a couple questions in the chat section that I can pitch out for you.
Okay.
You were just on a roll. I didn't want to interrupt. So,
Okay. Okay. That's fine. Um,
okay, so we have a question about the SEEG versus the EEG. What type of patient would need the SEEG instead?
okay, that's a great question. So, um, EEG, as we're talking about here, we generally also call it video EEG. Those are the types of procedures where you're admitted to the hospital. They attach the electrodes to your scalp. Sometimes they can put them on and you go home. They have the video that monitors you, and the scalp electrodes are essentially what are picking up signals from your brain. Unfortunately, if you imagine, if this is the point where the seizures come from, and this is the area up here where your brain is, that area, by the time that it reaches the skin or the surface of your skull, that seizure has diffused quite a bit. So looking at the surface of the brain of the skin and trying to figure out where the seizures are coming from deep in the brain is very, very difficult. In those patients, one of the options we can do is to place these SEEG electrodes. And what that does is that sits in the deep parts of the brain, and that can sample those areas of the deep parts of the brain and give us a much better idea as to where the seizures are coming from in those areas. Um, so it's not necessarily that SEEG it's kind of the second step after EEG. Let's say that you have an EEG done, scalp EEG, and it's very difficult to localize where the seizures come from. In those patients, for instance, that would be a very good indication to then go ahead and, one of the indications would be then potentially to offer SEEG. If one of the things I didn't talk about very much, but there's something called discordant testing. So if you imagine, let's say I do an MRI and it looks like there's a lesion in the temporal lobe, but then I do a scalp EEG and I see that seizures are potentially coming from the frontal lobe. And I do another test and I see that seizures are coming from a different area. Now, what that tells me is that we don't have one area that's clearly pointed to by all these non-invasive tests that we can go in and directly treat. That's, the corollary to that is that we do all the different testing and everything says, oh no, it's coming from the temporal lobe, for instance. If we see that, then we're much more, safe and capable and able to go after that area directly. When we see that there's discordant information. The seizures look like they're coming from multiple areas. That's when we have to go on and do one of these these invasive diagnostic procedures to get a better idea as to where the seizures come from. Does that answer the question?
I believe so, yeah.
Okay, great.
This is a little specific. This person who's messaging in says that their loved one is an LGS patient, but she is asking if there is such thing as having both a VNS and an RNS device.
Absolutely. So all the procedures I talked about don't preclude one another. So what that means is that we've had patients who had a resection before, like a temporal lobectomy, for instance. And let's say they failed that surgery, or maybe they had that done somewhere else and they come to us because they continue to have seizures. What we can do is we can, just because they've had that surgery doesn't preclude them from having invasive testing like SEEG, doesn't preclude them from having an RNS, laser ablation, any of those other treatments that we've talked about. What we find is that oftentimes there's centers where, let's say you've had SEEG before, you've had a resection before, if you failed that, some centers will say, you know what, you've had the gold standard, you've had everything we can do. There's not much more that we're able to do. What I feel very strongly about is that uh, those are the patients I consider to be difficult to treat epilepsy. It doesn't mean it's impossible. It doesn't mean that we can't do it. It just means that we have to work harder. We have to do more studies. We have to do other testing to really think about where the seizures are coming from. And we've had very good success with a lot of those types of patients. So to answer your question, just because you've had vagus nerve stimulation doesn't necessarily mean you can't have RNS or vice versa, or some other type of surgery afterwards.
Yes. I've even heard that there's a couple people out there with all three, DBS, RNS, VNS.
Yeah, exactly. So that's kind of what we're of that mentality, which is that we really want to treat your epilepsy, and we'll continue to work very hard until we can, get seizures better controlled.
Excellent. Okay. We had a question saying, does UCI treat pediatrics? You guys are an adult epilepsy center for the most part, though, right?
We are. My understanding is that because of the nursing staff, there's some privileging issue, and so that we're not able to care for patients under 14 years of age. At the age of 14 or above, we are able to treat anyone with epilepsy, and we've treated patients, at that age or younger. I trained at the Cleveland Clinic, and I trained doing pediatric epilepsy as well as adult. I'm very comfortable with all the types of epilepsy surgeries that we have, but due to the limitations of the hospital, we do 14 and above.
Okay, let's see. Our lovely Sophie's Journey advocate here said that Dr. Jeffrey Alaya is at CHOC, which is the local pediatric epilepsy center. So under 14, that's kind of the leading care, level 4 epilepsy. And they actually have a talk later today or tomorrow. I'm sorry, I don't work for Sophie's Journey, but later on in in this expo, both Jeffrey Alaya will be speaking about pediatrics. But yes, you actually are a pediatric epilepsy surgeon as well.
Right.
Excellent. If there's any more questions, pitching them now, that would be great. That is pretty amazing, Dr. Vadera. You got through your presentation, even though you were, doing brain surgery casually this morning.
Sorry about that, the last thing I'll say is that if there's a question that you have, if you don't feel comfortable asking here, feel free to email me. My email is svadera, my last name, and the number 1 at uci.edu. I'm happy to answer any other questions, whether that's related to surgery or other options that might be available. Feel free to call or email me with that.
Okay, I will go ahead and type that into the chat. So it's svadera1 at uci.edu, right?
Yep, that's perfect.
Okay, I have that down in the chat section down there for anybody who wants that. That's really great. A lot of doctors are not willing to share that, so it's very kind of you to do. If there's no more questions, I'll say again, thank you so much for joining on behalf of Sophie's Journey and Expo. And I feel very honored that, Epilepsy Support Network gets to work with excellent doctors like Dr. Vadera and his colleagues at UCI. And so thank you so much for seeing, it's good to see you.
Great, thank you. You as well. All right, thanks everyone. Have a great day.